and welcome to this FWN panel event. I'm Victoria Akintomide Akwamide. I'm part of the FWN exec, and I'm your chair for the evening. Tonight, we are looking at the reality that in the United Kingdom, Black women are 5 times more likely than their white counterparts to die giving birth. Several Embrace reports on maternal care and morbidity have highlighted this reality, and action and research is needed to understand the specific causes of these deaths. Tonight, we're asking the question of what policy measures should Labour be pursuing to end the appalling inequality in maternal health. This evening, we have a brilliant panel, and I'm very excited about the panel that we do have. We have Professor Nina Modi, who is the president of Imperial College London's Medical Women's Federation. She has a national and international profile as a medical leader and a clinical scientist. She heads the neonatal medicine research at Imperial and the neonatal data analysis unit. We also have Dr. Christine Ekechi. She's the chair of the Race Equality Task Force at Royal College of Obstetrics and Gynecology, and she specializes in early pregnancy and acute gynecology care. We also have Dr. Catherine Omotayo, and Dr. Catherine is a GP, and she's the founder of Mom's Pride. Mom's Pride is a platform that supports and encourages mothers from different backgrounds. She's a speaker, and she's passionate about Black women and caring women and mothers. We also have Justin Madis from the Office of the Shadow Secretary of State of Social Care, and he'll be speaking on what approach the Labour Party can take in terms of policy reforms in this area. I would like to remind our participants to engage with us by putting questions in the Q&A box. We'll be looking at the questions at the end of the panel, after all the panelists have spoken, and also we are recording this panel this evening as well. It will be available after the event, and our hashtag for the evening is FWN Lab 20, so that's FWN LAB 20. And so this evening we're going to kick off first with Professor Nina Modi, and Professor Modi, the floor is yours.
Thank you very much, Victoria. And just to, as I know this is being recorded, just to set it straight, I'm Professor of Neonatal Medicine at Imperial College London, and I'm also the current president of the UK Medical Women's Federation. I am not an obstetrician, so I don't look after pregnant women, but I do look after their babies. And I'm also the immediate past president of the Royal College of Paediatrics and Child Health. So I've got, I think, a broad view of policy issues as they relate to women and babies. So it's great to join this panel. Thank you very much to the Fabians for inviting me to this. You've asked me to set the scene. So let me give you, first of all, a few facts and figures, then mention a little bit about current context, and then maybe talk about a few reflections on how in this post-COVID era, we perhaps should be thinking in a very, very innovative and really, really constructive and positive way about the health of women and infants. So a few facts to set the scene. Just to remind you all, there are about 700,000 births in the UK each year. And about 80% of the UK population, give or take, is considered white. That's what came back in the last census. About 8% is of Asian origin, and about 4% are of Black origin. Now, as you mentioned, Victoria, in your opening preamble, that there have been a number of national reports from the National Perinatal Epidemiology Unit and Embrace, and these tell us that, for example, over the 3 years 2015 to 17, 209 women died in the UK, either during pregnancy or in the 6 weeks following pregnancy. Now, that means that in the UK in general, pregnancy and childbirth is safe. And that's the first thing I want to emphasize. It is safe in this country. That is not necessarily the case around the world, but in this country, it's safe. And the national figures for deaths of women in pregnancy in the first 6 weeks are 9.2 per 100,000. That means just over 9 per 100,000. It's a very, very low rate. But that figure conceals some disparities, as you've already alluded to. So that, for example, Black women are 5 times more likely to die in pregnancy or immediately after pregnancy than white women. Mixed race women are 3 times more likely to die, and Asians are twice as likely to die. The commonest cause of death during pregnancy is health disease. About 23% of those deaths were of women who had heart conditions, major heart conditions. And one of the very, very interesting facts that of that 23% of women who died because of a heart condition in pregnancy, 3/4 of them went into the pregnancy not knowing that they had a heart condition. Now that immediately tells us where we need to focus some efforts. It's about encouraging women to have good health care so that they know their own health problems. And it also means encouraging them to access antenatal care and good health care generally. So immediately leading into policy implications. But a current context is, of course, COVID. Now, again, the UK is doing some fantastic research, and some national figures show this relates to the first 6 weeks of from March to April, the first period of lockdown, as it were, when there were just over 400 COVID positive women who were pregnant over that 6 week period. Again, a very low rate of COVID positivity in pregnant women, 0.5%. But 56% of those women were from BAME backgrounds. Again, pointing to the fact that we're seeing a great intersectionality of disadvantage, because 69% of pregnant women who are COVID positive and were obese or overweight. And we all know now that those people who have comorbidities, who have high blood pressure, who have diabetes, who have other health conditions are more likely to suffer badly from COVID. So that's putting it into very current context. Now, there are other disparities in the UK that are unfortunately alive and well. So, for example, white women are much, much more likely to smoke during pregnancy, and that leads to all sorts of problems for their babies, which I, as a neonatologist, will see in my day-to-day activities. But does this all matter, is really the issue? And yes, of course it matters, because healthy women will have healthy babies, and healthy babies will grow up to be healthy, productive adults, and countries need resilient adults, productive adults, who for a resilient economy. So this feeds directly, I think, to the ears of the Treasury. If you want a healthy economy and a healthy, resilient country, then you have got to focus attention on the health of women and infants. Why is this even more a problem today? It's because so much of this is unrecognized, unmeasured, unremunerated, unrewarded. Let me give you an example. If a woman takes 6 months off to breastfeed, and breastfeeding is one of the most powerful health initiatives we can do for our babies and for societies. But if a woman takes 6 weeks off to breastfeed, she's going to take a financial hit. And if she's a career woman, she's probably going to suffer some damage to career progression. Why do we penalize women for doing something that is so important for societies? That is a question about how distorted our policy initiatives have become. We need to recognize childbearing and child rearing, breastfeeding, all these things that are unmeasured as great contributions to society. And we need to make sure that policies are developed that actually focus on recognizing the value to societies that these bring. A woman, let me end with giving you another stark fact. A woman who is diabetic has got problems with her own health, but her baby is going to be between 3 and 7 times more likely to become a diabetic in adult life than a baby of a woman born to a mother who's not diabetic. That means that we are passing on this burden to the next generation. But by removing the burden, by investing soundly, and again, this is a plea for the post-COVID recovery discussions, while we are focusing minds on where we should focus investment, let me put out a plea to everyone who's involved in policy. Justin Matters, please take this to your colleagues. If we focus policies on the health of women and babies, we are going to prepare our nation to be resilient, to be productive, to be economically viable, and we are going to pass those benefits on to future generations. Let me stop there, and I hope we can pick up some of these thoughts in the discussion.
Thank you so much. I love the focus on the economy. As someone in finance, I'm like, yes, it makes sense. Yeah, It absolutely makes sense. We're going to then go on to Dr. Ekechi, and I would love to hear your thoughts from a Race Equality Task Force perspective and your view on the matter as well.
Thank you, Victoria. And thank you, Professor Modi. As a colleague of mine at Imperial, you have touched on all of the bases that very much underpin the work of the Race Equality Task Force. So as Professor Modi has described, very clearly, we have this huge disparity in outcomes as it pertains to maternal mortality. But it's important for me to pick up on the fact that the biggest disparity is within the outcomes between white women and women who are racialized as Black. And what we unfortunately have been finding is that this disparity has been stagnant and in some years actually increasing, despite a number of interventions that have been implemented in the intervening time. So it's important for us to really try and unpick this. And what we do know is that the reasons are complicated and not very well understood. Again, as my colleague pointed out, there are certain things that we do know. So, for example, Black and Asian women are more likely to have pre-existing health conditions. We know that within immigrant populations, they tend to be from Black and Asian backgrounds, where language barrier and access to antenatal services may be an issue. But we also know that this is not the complete picture. We know that for Black and Asian women, where pre-existing medical conditions is not of concern, where English is their first language, and where they do not have any of the other markers that indicate social deprivation, they still are at greater risk of maternal mortality compared to white women. The other thing that we need to understand is that whilst we're looking at maternal mortality, and again, I wish to stress the point that maternal mortality in this country, thankfully, is extremely low. What we miss are all of the women who survived but have been harmed through their pregnancy journey. And in medical terms, we term that morbidity. And so for every one woman that has died, we're missing 7 to 10 women who have suffered harm. And this is important because mortality is just the tip of the iceberg. And we know that when we look at morbidity, we still see this disparity in outcomes. So it's important for us to really try and unpick this and to ask the deeper questions. Where we know that Black and Asian women are more likely to have pre-existing health conditions, we need to ask why. And really what we do understand is that the social determinants of health intersects with race. So as a party, really, if we're looking at solutions, we really need to ask the deeper, harder questions, which is why are Black women specifically at greater risk? One of the things that we're starting to understand and starting to acknowledge is where unconscious bias, conscious bias, racism, be it at a structural and institutional level, may play a role. And it's important when we talk about these difficult topics that we do acknowledge that this is not something that is done consciously or implicitly for the most part. But I think it's important that we have these very difficult discussions to understand how this plays a part in how women access healthcare, how they are perceived within healthcare settings, and how that may impact the care that they receive and finally their outcome. So within the Royal College of Obstetricians and Gynecologists, we understand this. This is not a statistic that we continue to stand by. We understand that for us to try and make an impact, we have to acknowledge not only the poor outcomes as it pertains to maternal mortality, but also the impact in the career progression for our members, our trainees, and our fellows in the college. i.e., we need to have a diverse workforce. Our diverse workforce is as important as the women's health outcomes. And unfortunately, we know that there is something called differential attainment, which means that for white doctors compared to Asian doctors and Black doctors, their career trajectory is not the same. So for the Race Equality Task Force at the RCOG, we are focused on looking at the outcomes as it pertains to the trainees and members, essentially the doctors who are going to deliver this care, making sure that all doctors from all racial backgrounds have the cultural competency and sensitivity to deliver the best quality care for all of our women. and also to focus on the healthcare outcomes for women. And again, as Professor Modi brilliantly described, that there's no point us just focusing at the point of maternal care. It's almost too late. We want to prevent the pre-existing health conditions from arising in the first place. So this is important. It means that we have to tackle disparities as they exist at the point at which a child is born. We have great statistics around maternal mortality, but we're not very good at the statistics around other aspects in women's health. And so we need to look at the life arc of a young girl. We want a healthy young female child to be a healthy young teenager, and that healthy young teenager will become a healthy young woman, and a healthy young woman who is pregnant, and so on. So when we are looking at solutions, it's important that we pan back and that we close the data gap as it pertains to the other aspects within women's health and child health, and really health overall. And as the Labour Party, I would implore that really we focus on tackling the social drivers to inequalities. Otherwise, these disparities will continue to exist.
Thank you so much, Dr. Akechi. Thank you for highlighting the fact that there's a multifaceted element to this, that we need to look at the different things that's happening before we can even have any solutions whatsoever. I think that's very important, and something that I really want to touch on as we move on. And over to Dr. Motayo, and I would love to hear about the community responses that many organizations that you've experienced in terms of how Black women are experience maternal care specifically.
Thank you very much, Victoria, and thank you very much for this panel as well. So what I really want to highlight is what my women, I can call them my women in the group, Mums Pride, have been experiencing, and also a lot of my colleagues and friends who are, most of them, obs and gynae trainee, and also mothers. So first, just to kind of highlight what Mums Pride is about, it's a community group of women, 99% of them are Black, from different backgrounds, and it's a platform for them to feel encouraged and supported through the whole journey of motherhood from pregnancy. Especially during these times, the topics that we talk about have been quite focused on the experiences with the different rules and, you know, the lockdown situation as well in the hospital and at home. So what has been highlighted, unfortunately, is the level of anxiety. And not just from the fact that we have a lockdown and things keep changing week by week, but also because a lot of them are first-time mothers that are not given the opportunity to fully experience the process and the journey of motherhood. Going to the hospital, having your partner there, during prenatal consultations, during the labor itself and after, is very crucial. When you ask any mother about their pregnancy, the first thing they talk about is the delivery and what's going on before then. I am aware that different hospitals have now tried to revise their different rules and trying to encourage some partners to come from certain specific periods of time. As much as that shows improvement, is not enough right now, because women are given, you know, Dr. Christine and Dr. Modi as well can tell that people are giving birth all the time. And depending on where you are as well, you will find a different experience. Now that leads to the last campaign that I've been part of called 5x more, 5 times more, which does highlight, like we've been saying, that Black women are 5 times more likely to die, but also highlights what we can do from the community to improve these numbers and these figures. One of the main things is to find someone to speak out for you, find someone to vouch for you, find someone that you can relate to and can speak on your behalf. Now, it's very difficult to find someone that you don't know, i.e. a midwife or a nurse or a doctor, when your partner will have been that person. So there is that level of frustration that you want to speak out, you want to find a person to be your spokesperson, you want to feel heard, you want to feel included, but that connection has been cut, has been taken away from them. And there is a lack of understanding as to why, because certain rules are allowed in certain things. For example, children are going to school, you can still meet some people at the restaurant, but having the person that's been at home with you the whole time not coming with you to even your scan, your first scan, which I remember as a mother was a huge experience. I can never forget how that was for me. That's been taken away from them, and that's really sad, and it's really heartbreaking to hear. It is what we're trying to do, especially because within the group we have a group of doctors from different specialties. We're trying to give that information. As you know, the speakers before rightly did point out, we know that there are different risk factors that puts a Black woman in a higher risk. We know that there's health conditions, cardiac conditions, which are also without the pregnancy, without the race, puts you at a higher risk of mortality as well. Having said that, we are trying to educate them, and I think that's the positive thing that's come out of it. There are more groups and more events that are focusing on the health promotion. And as a GP, we really value that. I do speak to my patients who are also pregnant about their health conditions, because that's what we do as taking care of them from a holistic point of view. But it is very difficult to try and do something from our side when someone is continuously taken away from them and from the experience on the other side. So I am kind of pleading, my biggest plead is to find a way to still give them something, give them the opportunity to experience, to have that support. I created this group because I had all the support from my friends and family, but because I didn't have many friends that were pregnant, I felt alone. I literally felt alone. And imagine going through that without your partner who was there from the beginning. So my plea is to try and create that bridge, that gap that is huge, and I think is very detrimental to also decrease the disparity in the risks. Having said that, like I said, we have a lot of mothers that are from a medical background, and you would expect a bit more understanding in terms, or accepting rather than understanding, accepting of the situation. And maybe you expect the experiences to be more positive, but I assure you that it's the same. Whether or not you have the medical background, you put your mom hat on when you're going into the hospital. And it is sad. It is sad to hear from these moms that are very anxious. Their mental health is, might also be affected by it because of this experience not being what they wish it was. And whatever happens during your labor, it never leaves you. It never leaves you. We don't talk about the pain. We talk about the experience. We talk about that midwife. We talk about that doctor, that person that spent some extra time with them, that person that listened to them, that person that understood that their pain wasn't because of a racial or a telltale that someone came up with before, and that's why they were disregarded. It means a lot. The experience is a lot. So that's my main focus right now. Thank you.
Thank you so much, Catherine. Thank you so much. Before we move on to Justin, I'd just like to remind participants to use the Q&A button to send in questions. We will be addressing these at the end as well, and we will be putting the questions to our panelists, and we would love to get a good discussion going. So I'm then going to hand over to Justin Madders. So Justin is a Member of Parliament for Ellesmere Port, and is part of the social care ministry, and he's going to just touch on the Labour's response to this matter. Justin.
Thank you very, very much. Yes, so I'm filling in for John Ashworth tonight, as you probably gathered, with COVID having a new twist and turn every day. Quite often he's called away to other things at short notice, but I'm very pleased to be here. My brief in the Shadow Health team covers secondary care, workforce and patient health, and within that actually maternity services is included. So I'm probably the right person to have here today. And of course, we have been dominated in our everyday lives by the impact of COVID, but the stark statistic that we've heard from all the speakers tonight about the 5 times more campaign is really something that any government should be looking to address. That is something that we simply shouldn't be tolerating, and of course it's a very multifaceted issue, which will require, I think, a whole range of interventions to deal with. But I believe that actually part of this conversation tonight will help us come up with a plan to do that. I think the fact that the impact of healthcare on BAME communities is something that is now much more at the fore because of the experiences, sadly, that we've had with COVID. And I think it is bringing out some of the issues that people have mentioned today about structural inequalities in particular. And just addressing the point that Nina mentioned earlier on, absolutely, totally agree with her that if we get good maternity care, good starts in life, we give so much more chance for those children to grow up healthy and wealthy and wise throughout their lives. And it's really so important that we do that right. And that's obviously one of the reasons why we were so proud of the Sure Start centres all those years ago, and we're so unhappy that they have been one by one dismantled. But that doesn't mean that it's not something that we should be trying to rekindle in some way, because absolutely a child's life chances can really be affected by those first 1001 days and what happens beyond. But I think that for the purposes of tonight, we want to try and discuss and understand and try and come up with some strategies to really eliminate or reduce that link between ethnicity and death during pregnancy. And I think there are a whole range of issues, some of which we touched on. It could be training, it could be more resources and support for the women themselves, it could be of a wider societal issues that we need to look at. There are in society already quite wide regional variations in terms of stillbirths, for example, in the NHS. Be interesting to see whether there is any overlap between that and ethnicity. But what it does show actually is that although, as was said earlier, childbirth in this country is very, very safe, it isn't evenly distributed, and we want the best practice and the best outcomes for everyone. And absolutely, there's certainly a challenge there. We know that NHS England have actually announced recently they're going to try and set some measures to reduce these inequalities, but there isn't actually a target that they've set themselves. In the maternity world, there have quite often been a lot of targets set in terms of reducing some of the issues we get with childbirth. We haven't got anything tangible that we can actually hold the government to account in terms of that particular challenge. And we know that there was a petition recently, and the government have announced that they're going to actually look at fund a study, in fact, into the factors that might contribute to these different outcomes. And from the Labour Party's perspective, we've actually got Doreen Lawrence conducting an inquiry into it's more about the impact of coronavirus on BAME communities, but there's no doubt that many of the recommendations that she comes out with, many of the findings and issues that she brings up there will, I'm sure, equally apply to this particular area. So I hope that we have some really good exchanges of ideas and things that we can feed into our policy making. Obviously, we are a considerable way off putting our manifesto together, but there's no doubt this is something that actually can't wait till 2024. It's something that we need to be pressing the government on now. And each year, Parliament in Baby Loss Awareness Week usually holds a debate on the subject of baby loss, and it actually covers the whole range of issues in terms of maternity care. And this particular issue of the that we're discussing tonight hasn't actually, I think, had as much attention as it deserves. So I think that because Baby Loss Awareness Week is actually next month, it would be hopeful that we will get a debate in Parliament on it at that point. So I think this is really a good time for us to actually bring forward some of the hopefully positive suggestions we're going to get tonight. So I look forward to hearing some of the contributions and hopefully picking up some good suggestions to move forward.
Thank you very much, Justin. Thank you for focusing on that policy front. We're going to come back to that policy discussion as well, but I just want to quickly address some of the questions that some of the attendees have sent in. And we have Faiza Salim, and who asks, how can we influence OBS and gynae and midwifery teaching to improve the care they receive? So I would like to address this to Dr. Ekechi, because you mentioned the importance of teaching the staff member the right way when it comes to giving care to Black women. So how would you respond to Faiza's question?
So we at the Royal College of Obstetricians and Gynecologists, and specifically within the Race Equality Task Force, know that this is central to us really tackling this problem. So the Race Equality Task Force will work on 3 streams. The first stream is to look at all of the outputs of the college. We are an amazing organisation that produces guidelines to help direct care, both for clinicians and also developing information leaflets for women and their interested partners who are pregnant, and indeed throughout women's health. But it's important that all of our output is reflective of the cultural population through which we serve. So we are doing a huge piece of work looking at that. The second stream, as I said, is looking at differential attainment and outcomes. But within that, the wider lens that we are looking through is education. So education, not necessarily in a didactic form, and not to place blame in any one spot, but to understand that we all hold biases and how those biases influence the way we receive care. There's great work that's come out of America that shows that patients are able to pick up inherent biases held within clinicians. That then affects how they receive the information that is fed to them by the clinicians. We also know that where clinicians hold biases, they are less likely to involve the patients in the center of their care in planning treatment outcomes for that particular patient. They're less likely to put the power back to the patient. So it's important for us clinicians to understand this and to understand that where we may hold those biases, what we can do to reduce them. Because in reality, the likelihood of us being able to remove them is quite difficult. And I think it's important that we are realistic in what we are asking for. And then the third outcome, as I talked about, is women's health outcomes. But it's important that through medical school, we understand that these disparities exist. Now, that means that we really need to look at the curriculum, and we should approach it not as an equality, diversity, inclusion that's a tick box mandatory exercise to tag on at the end, but see it as something that is central to the way we deliver healthcare in a diverse country such as the UK in which we live. So that larger piece of work is looking at how we can make our curriculum culturally sensitive, culturally intelligent, and also breaking down some frameworks that haven't really worked well for certain disparate groups that we know are at risk of poorer outcomes.
Thank you so much. I love the emphasis on we need to deal with the issue before the practitioners start working whilst they're being trained. And I have another question here that I'm going to direct to Dr. Omotayo. This is from Atinuke. She's part of the 5 Times More campaign. And then she said, first of all, said, thank you for setting up this event and for the knowledge that the speakers have given. And then our question is, would you say that when professionals talk about the conditions Black women are more likely to have, this pushes the blame back on Black women, even though Black women may be more likely to have certain conditions? This shouldn't warrant the 5-fold disparity we are seeing and have been seeing for decades.
Thank you for that question. I think I see where that question is coming from, because we as Black women, I feel like a lot of the times we just take the blame for certain things. And in this case, as we're talking about the biggest reason why we have this disparity is because of health conditions that are there from the get-go. I think we should take responsibility of our own health rather than to take or feel like we have the blame of certain things. And that goes all across the board. I think we should be responsible to make sure that we can be in the best health. So also be aware of the conditions that we have, be aware of what they mean. Having said that, we can't, coming from a person who is a GP and sees what the community is saying, and also the people around me, there is still loads of lack of knowledge. The lack of knowledge is, as much as we can continue have teaching sessions, we recently had a chat, and we recently had an event that was focusing on women's health. That is very helpful for certain people to get to know some of the information, but then to have the understanding, being able to speak to women to a level of their own understanding their culture, where they come from, I think that is what we need to highlight. I think it's important not to feel like you're blamed for everything, and a lot of people do that. I think from our side, we should learn to just get to know, have the knowledge, know what to do with that knowledge, and put your health on the best platform. From the other side, as a clinician, keep teaching, but also be aware. And as Dr. Kechi said, we need to go from the beginning. And yes, we're talking about pregnant women, we're talking about women, we're talking about Black women. Let's start from the fact that in medical school, we don't see anything on Black people. I'm sorry to say, we don't see it. We don't see a lot of things on dark-skinned people as well. So it's hard to teach a topic that it's quite focused on one type of race, and then use that to then cater to everybody. One foot doesn't fit all, it doesn't. And that's what we're trying to do on the level ground. That's what other people like Dr. Christine as well is trying to do on her level as well. But it takes everybody's effort to make that change from both sides.
Thank you so much for that, Dr. Matayo. And I just really want to bring it back again to policy, and I'll just address this question to Justin. This is from a member of the audience, and they've asked that since the Embrace report, so let me just give a bit of context as to the Embrace report for those that might not be aware. So it was the Mothers and Babies Reducing Risk Through Audit and Confidential Inquiries that was done for the entire UK, and which then raised the fact that Black women are 5 times more likely to die from childbirth. So since that report, the question is, since the Embrace report, what policies were present and changes have been made since the report was released? So from the, perhaps Justin, from the Conservative government perspective, what have they done? What do you think needs to be done better? And what would Labour do if in power? Well,
it's a very good question. Always a good question if I don't know what the answer to it is. And I suspect, I think the report only came out, was it about November last year? I very much doubt much has been done, and you know, we can take that as a political criticism, or we can take it as a reality that actually coronavirus has just absorbed all the focus in the NHS. But there are lots of areas like that where things that the NHS were hoping to do, new plans, really important stuff, has just not happened because all the attention has been elsewhere. But it's a very, very good question. What I'm going to do is actually put in a written parliamentary question on that, because I think if nothing else, it will serve as a timely reminder to the minister, actually, that they should be asking their officials the question that I've just been asked now.
Absolutely, and considering the fact that next week is Black Women's Maternal Care Week, and I think that's also timely to see what the ministers are going to do about it as soon as possible. Just to move on to another question that we've got in. The question is from Chinedum. It's asked, in addition to the clear power of re-education through culturally sensitive intelligence, what else can be done to contribute to the reduction in maternal mortality rates amongst women of BAME descent? Dr. Modi, I think this will be something that you could perhaps address.
Thank you very much, Victoria. Yes, happy to do that. In fact, I was just starting to type out an answer to that.
Great.
So let me say, I think this is really about the wider inequalities that exist within society at large. The racial inequalities, the gender-based equalities, and of course these intersect, as we've just been discussing today, and all of the other inequalities that unfortunately are so prevalent in society today. So it is a good question, it's a wider question. What can we do to eliminate this? Slowly, surely, but steadily. I would say it's a circle, it's a cycle of life, and we need to think about what we do now that's going to benefit not only this generation, but the next generation. So let's start with educating boys and girls to prepare them for parenthood. Let's talk about, as I mentioned previously, actually measuring and valuing these unremunerated contributions to society that come, for example, with childbearing and child rearing. Let's make sure that disadvantage doesn't impact on the multiple ways in which it does now, so that we've spoken, for example, about comorbidities and how certain groups in society have multiple disadvantages when it comes to health. Let me widen that to think about, for example, atmospheric pollution. It's, again, there are good data that show that BAME women are much more likely to live in areas that are very, very highly polluted. That is going to have an adverse impact on their health, on the health of their unborn babies, on their infants as they're growing up. And you can see that spiral of disadvantage and inequity widening. So any government that is really, really serious about the health of its population, and it should be, because of course, I say the health of the population is key to a healthy economy and a resilient society, and COVID has done nothing if not exposed this very, very, very clearly. Any government that is interested in this should start thinking about innovative ways to address this. I'll give you one very innovative example. Angus Deakin, who is a Nobel Prize-winning economist, suggested that we should throw out GDP because it does not incorporate these unremunerated contributions to society. The health of women, for example, is not measured, and the things that contribute to the health of women and infants are not measured. So when we're thinking about how to position ourselves now, we're doing it on the basis of metrics that are flawed. The other thing I would absolutely say is that we need a healthcare system that works well for everyone. We are moving progressively towards a more and more marketized healthcare system in this country, very sadly, away from the founding principles of the National Health Service. We need to get back to bringing equity and efficiency into our healthcare system. Another challenge, I think, because we all know we've drifted away from that. So those are just a few thoughts. I could go on about this for quite a long time, Victoria, but let me stop there. These are just a few thoughts.
Amazing. I'm going to need you to just answer another question as well, and I think it's quite a good question for you. And this one is from Elizabeth, and she asks: is there a similar disparity in neonatal mortality and morbidity outcomes from your experience?
There isn't. There are differences. There are variations in outcomes. But what my own research, as well as that of others, shows that one of the stark findings about variations in neonatal outcomes is that yes, they're geographically based. Yes, there are variations between racial groups. Yes, there are variations between socio-demographic groups. But there is a very clear north-south divide, with outcomes for babies, sick babies, babies admitted to neonatal units, being generally worse in the north of the country than the south of the country. Now that brings up all sorts of other discussion points about inequalities within our societies and the causes, the root causes of these inequalities.
Thank you very much for that. I'd just like to address the next question to Dr. Ekechi. We touched on previously of the importance of education and educating healthcare professionals properly before they start practicing. And there's a question here from Angela, and she asks, how can we make BAME issues a more central part of the medical school curriculum without resorting to racial sciences?
Thank you. I just want to go back to the question about, do we see similar racial patterns when it comes to neonatal outcomes? We do know that as it pertains to stillbirth, which comes under the remit of obstetrics, Black women are 3 times more likely to have a stillbirth compared to white women. So we do see this, and I agree wholeheartedly with Professor Modi that we also see this stark north-south divide. So what we know is that poverty and deprivation intersects with race. We know that Black and Asian people are more likely to be in the lower social classes. So when we add these additional factors, you can see that a Black woman in a lower socioeconomic class is likely to fare worse out of everybody. But yes, absolutely, we do see this very, very stark north-south divide where the south is more affluent compared to the north. So whilst we have lots of talk about levelling up, as a Labour government, really, we have to say, what does this actually mean? And how are we really going to implement this so that we see this difference? Because this impacts not only in terms of economic output, but also health outcomes.
Mm.
When it comes to BAME, and as a term, it's not a term that is incredibly useful, because essentially it means everybody who is not Caucasian. And what we tend to lose in that is that we're talking about women who are individuals. So identifying people by race doesn't tell me anything more than how the society treats people who are racialized by definition, because the only commonality they have is the degree of melanin in their skin. There is no genetic commonality between Black people, and there is no real genetic commonality between Asian people. And so when we're looking at data, we have to be more intelligent about how we collect that data. If we're looking by ethnicity or where a group of people have come from, that may give me a little bit more information. For example, maybe how cultural influences from their country may determine health-seeking behavior, or their diet, for example. They may be more likely to have some genetic commonality. But to place somebody who is Nigerian, for example, with somebody who is South American Black or Jamaican is not really going to add anything more. And so I think it's important that we don't fall into this trap. I know that the question mentioned Angela Sani, who I respect greatly. And she talks about this fallacy. In a way, it's something called ecological fallacy, which means where we make inferences at population level and try to use those same inferences at an individual level. And invariably we find that it doesn't quite work. So when I talk about education, yes, when we split data up by race, it can give us an idea of certain groups at a sort of higher level that have greater disparities. But again, the solutions applied at race level really are tackling the social inequalities and how that pertains to race. But as I said, maternal mortality is very, very complicated. And there are many other factors that we know play into this. And so this is really important because there have been interventions that have been implemented when we have noted that there is this disparity. For example, there's been lots of money focused on providing translators for newly arrived immigrants, for example, making sure that leaflets are translated into the correct language. And community services, when we did have them, worked very well. But they didn't close the gap as greatly as we would expect. And so again, we have to then ask ourselves, these implementations, have they been at the right level? Or have they only served at particular areas and not at others?
Thank you so much for just like bringing those two aspects together. And I also like to bring us back again to a policy front. So Justin, I would like you to touch on the point that Professor Modi raised earlier in terms of the importance of having an economy that allows for healthy infants and healthy mothers. Because fundamentally, a woman that can't feed herself, that can't feed her children, that can't have the right nutrition during pregnancy, of course she's going to have repercussions in during birth. So from ensuring we have the right economy perspective, what can the Labour Party do in terms of policy wise, specifically for women that are in disadvantaged positions, that are not in the best economic positions, to ensure that their pregnancy is successful?
Well, it's a really, really important point, and I'm certainly a big fan of the Professor Marmot approach of health policies in all, which I think is as good a place to start as any. And certainly, I would like our policy making process going forward to have that as one of its central themes throughout. There's no doubt that that kind of approach could make a difference over the long term. And you're certainly right. It starts at, it starts before conception, doesn't it? Of course, it's about making sure that there is good public health advice. We know that sector has been decimated over the last decade. It's about making sure that there's good pre and antenatal care. I think the continuity of midwifery services is something that we know the government want to introduce. That's I think some way off still, unfortunately, but I think that has the potential to make a real difference. I mean, we're still several thousand midwives short of where we need to be. And then if you look at the wider economic factors, of course, there is a question about maternity leave, about whether our childcare system is really well set up enough. And of course, there's the whole issue about family support as well. And clearly at the moment, that is a huge challenge. Well beyond what we would ever have thought to see. So I've no doubt that actually when we really sit down and go through each policy area, be it the workplace, be it public health, be it the benefit system, be it education, we will find there are lots of interventions that we can come up with that will actually really help achieve that aim. And I would really pleased that if we can come up with a very credible and permanent set of policies that will make a difference over the long term, because these are the sort of things actually it can take 5 or 10 years before you have the evidence base to show that the interventions have had an effect. And this area is more than any one that has to be looked at over a generational time period.
Absolutely. And I also think that it's important to not only have the policy and have the services, but ensure the right women are getting the services. So specifically targeting the community groups of Black women, and knowing that and informing them that these services are here for you to use. I think oftentimes there's a lot of services that are created, but it's not targeted to the people that need it the most. And I think going forward is important for any of the for the Labour Party and other parties to ensure that the right people are getting the service. We are. What was that, Dr. Ekechi?
Sorry, if I may jump in.
No, please do jump in.
With what Justin had said, I think it's important that when we talk about it, we really provide solutions that start off with easy pickings and then larger interventions. And one of the things that we have found within maternity is that there hasn't really been a good review as to the impact of the interventions that have been applied so far. So we do not know what has worked. We do not know what is working. And I think it's important that before we throw money at new interventions, we may find that we don't need to reinvent the wheel. And it's important to then stop focusing money on interventions that haven't worked so far. What we do know that does work are community services. And it's really important that we try and support the current government, to really try and re-establish that link between the community and the hospital. Because we have to remember that a great degree of maternity care happens in the community with GPs, such as my GP colleague here. So focusing it at the point at which a woman arrives into hospital, again, is almost slightly too late. We need to empower women and empower women within the local communities that they live in.
Absolutely. And ensuring those community groups are getting the right resources, financially especially, is also very important. We're running out of time, which is very sad. But thank you guys so much for just giving up your time. And I'm looking forward to the question you're going to raise, Justin, in Parliament's Prime Minister's question. So
send me an email and I'll make sure you get the answer.
Absolutely. I am going to follow up. Of course. Okay. Absolutely. So today we've talked about the importance of having a robust economy that supports Black women, that supports women that are pregnant women. We talked about having curriculum that teaches students that are going to be healthcare professionals the right way, that teaches them about race and how to treat Black women, and the importance of community groups to deliver effective maternal care for Black women. And these are important aspects of a bigger picture, and it's a conversations that we're going to continue to have, and it's a policy push that we're going to continue as well. Thank you very much for our panel. Thank you for our audience members as well, and for the amazing questions that you guys have posed tonight. It's been great having this discussion. This event is part of our FWN event during the Labour Party conference, which is happening virtually this year. And our next event is about women in writing, which is with Rachel Reeves MP and Yvette Cooper MP as well, which is on Thursday. And thank you very much for joining us this evening. We've recorded this, so we're going to put this up as well. And I hope everyone has a fantastic evening. Thank you very much for joining us. Thank you.
Bye, everyone.
Bye, guys.